Great. So today we are joined by a very special guest speaker, David. He is a current third year MD PhD candidate in health policy at Virginia Commonwealth University. His research focuses on epidemiology, health economics, clinical care, and substance use disorders, with particular emphasis on the emergence and spread of novel adulterants within the fentanyl-dominated illicit drug supply. He has published more than 60 peer-reviewed research papers in leading journals, including JAMA Internal Medicine, JAMA Health Forum, BMJ Injury Prevention, and Nature Scientific Reports. He is also the founder and director of the Center for Integrative Social Medicine and Population Health, a national research collaborative that brings together students, researchers, and health professionals dedicated to reimagining how medicine engages with society. He has also received multiple awards and honors, including the Diana Award, Boston Congress of Public Health's 40 Under 40, the National Minority Quality Forum's 40 Under 40. So he's a very accomplished individual, and we hope that you enjoy today's session. So with that being said, I'll pass it over to David.
All right, thank you so much, Danielle, for that introduction. Just before I start, can I just get a show of hands or in chat? Is anyone interested in pursuing like medical school or like a degree in research or like STEM, health sciences? All right, cool. As Danielle mentioned, I'm an MD PhD candidate. So, what that means is I am currently doing medical school, which is the MD component, and I'm also doing my PhD in health policy, which is more on the research side. So, a lot of my research will touch on themes that I hope that you will find interesting and sort of translating frontline patient care experiences with broader research trends. Without further ado, let me share my slides. All right. Can everyone see these slides? Okay, perfect. Um, just to set the scene, who here has heard of the overdose crisis or the opiate crisis? All right, so the opioid crisis is a public health epidemic. It was started really in the early 2000s through the widespread prescribing of prescription opioids, including oxycodone. There were companies, including Purdue Pharma, that were promoting oxycodone as this miracle drug for pain and chronic conditions, and they really downplayed the side effects of opioids and the risk of addiction. And this really started off wave one of the overdose crisis. But over time, we began to see some pretty dramatic changes in the landscape of the overdose crisis. For instance, around 2010, we began to see prescription opioids like oxycodone replaced by heroin, which is higher potency. It could be manufactured by illicit drug manufacturers. And then in 2013, we began to see a huge shift. So if you take a look at that blue line and that red line, you begin to see that around 2013, the overdose crisis really skyrocketed. Like it became very, very sharp. And this was really due to the proliferation of fentanyl. And there's a few reasons why fentanyl really increased overdoses so much. So first, heroin is very expensive. So for drug manufacturers who are trying to make a profit from selling drugs, they decided to actually replace heroin with low-cost fentanyl. And fentanyl, if you just put a tiny little bit of fentanyl and you add some inert pharmaceuticals like acetaminophen or other sort of bulking agents, you can essentially achieve the same level of potency without spending as much money as if you just made that batch using heroin. So this really allowed drug manufacturers to increase their profits. But because fentanyl is so potent, a tiny little sliver of fentanyl can cause an overdose. And so this dramatically increased the drug overdose crisis. Um, and then finally, if you look at that red line, which is wave four, we started seeing around 2015 fentanyl being mixed with many different types of novel adulterants, including xylazine, which will be the topic of today's presentation. But in addition, there are other stimulants and other sort of compounds that are increasingly being mixed with fentanyl to produce like different psychoactive effects, so that drug manufacturers can continue to sell their products and sort of differentiate themselves against market competition. So really, this fourth wave of the overdose crisis is the focus of like the contemporary drug overdose crisis. It's changed pretty dramatically since the first wave with Purdue Pharma and oxycodone, but what this has really done is it's created challenges for physicians to manage overdoses. A lot of you are interested in medical school, so what we're seeing nowadays is this flooding of the illicit drug supply with many, many types of novel adulterants, and this is very hard for us to treat within a clinical setting because it can change the way that people respond to medications like buprenorphine or methadone. It can change people's risk for overdose, and it can also cause other effects other than overdose that can negatively impact health. So within this context, the story of xylazine is very interesting. Around 2010, we began to see streets of Kensington, Philadelphia. People were sedated for hours and hours at a time. They could not be woken up. These people were obviously oftentimes in bradycardia, which means low heart rate. They were often hypotensive, which means low blood pressure, and a lot of times, these people were also vulnerable to theft or assault. And we began to see these news reports of these drug deaths tied to trank soaring across the US. And people called it an animal sedative, bringing fresh horror to US drug zones. There was a lot of stigmatizing language, including this concept of like this flesh-rotting trank and portrayal of people who use drugs as like zombies, because xylazine can cause these skin ulcers. So really, like, people did not know like what this substance was and why it was rapidly infiltrating the streets of Philadelphia. So what xylazine is, it's a non-opiate sedative, analgesic, and muscle relaxant. It belongs to the alpha-2 adrenergic receptor agonist class. It was initially developed as an antihypertensive in 1962, but it actually never gained approval for human use because of its profound side effects. In 1970, it was exclusively used for veterinary medicine. So given that this is sort of a neuroscience organization, I wanted to tie this in with some neuroscience concepts. So, as you guys are very well aware, the nervous system consists of a few different components. The central nervous system, which is sort of, your brain and spinal cord and executive function. And then there's also the peripheral nervous system, which is heavily involved in sort of things like voluntary muscle contractions, which is part of your somatic nervous system, as well as your autonomic nervous system, which is sort of your autonomic functions, including blood pressure, heart rate, sweating, and other sort of autonomic functions. And in terms of the autonomic nervous system, that can also be broken down into sympathetic and parasympathetic. So sympathetic is what you would imagine your body to do if you were being chased by like a bear and you needed to like activate your muscles and you needed to like dilate your eyes to see better, and you needed to, like sweat to like dissipate heat when you're trying to like move quickly away from that situation. And your parasympathetic nervous system, which is sort of the rest and digest system of your body. So as I mentioned before, xylazine is an alpha-2 adrenergic receptor. So for those of you who may not be familiar with what an adrenergic receptor is, it's essentially a heterotrimeric protein, G protein coupled receptor. And how this works is once a ligand binds to the receptor, the GPCR, it induces a conformational change in one of those three trimeric subunits, so specifically the alpha subunit. And the alpha subunit then releases this molecule called GDP and exchanges it for GTP, which is the triphosphate version of the GDP molecule. And this can induce the alpha subunit to become either the GS subunit, the GQ subunit, or the GI subunit. So in terms of the adrenergic receptors, the alpha 1 adrenergic receptors are receptors that are involved in is a GQ receptor. So it essentially once GQ gets activated, there's a lot of downstream signaling. So it activates PLC, IP3, DAG, and then that increases calcium. And calcium is used by our skeletal muscles for contraction. So what it contracts specifically are things like the iris, which um, it contracts the radial muscle of the iris, which causes pupillary dilation and allows you to, activate that component of the sympathetic nervous system. It contracts your vessels, which causes vasoconstriction, and that raises your blood pressure, and your ability to sort of, funnel blood to tissues that are required for your sympathetic nervous system, as well as things like your prostate and your nasal vessels. So alpha 2 is where xylazine is sort of mainly affecting, and alpha 2 is essentially the brakes of the sympathetic nervous system. So it involves a GI subunit, and once GI is activated, it decreases adenylyl cyclase. And adenylyl cyclase eventually lead to less calcium production and muscle relaxation. So it sort of acts as a negative feedback center of the sympathetic nervous system. So if you think about a drug like xylazine, which is an agonist, so what an agonist means is once it binds to the receptor, it activates the receptor, in contrast to an antagonist, which inactivates it. So xylazine is an agonist of the alpha 2 receptor. So once alpha 2 is activated, you have muscle relaxation, and that causes, people to be like very sedated. Their muscles are super relaxed, and they're often, sedated for long, long hours. In terms of the other receptors, there's things like beta 1 receptors. So this is a GS subunit. And GS eventually leads to increase in calcium and contraction. So if you're being chased by a bear, you need more calcium to contract your heart and increase ionotropy. So ionotropy is how strongly your heart is able to contract. So this helps you sort of, activate your sympathetic nervous system as well as your kidneys. So specifically, there are cells within your kidneys called juxtaglomerular cells or JG cells. And these cells are involved in the RAS system. So they release renin, which is R in RAS. And then renin then activates things like angiotensin and aldosterone, which then raise blood pressure. So again, involved in sort of the sympathetic nervous system. And finally, you have things like beta 2, which is also GS and involved in sort of dilating your bronchioles to help you, take in oxygen quicker into your pulmonary system, and beta 3, which is involved in bladder relaxation. So within this context, we have this novel adulterant called xylazine, which is an alpha 2 adrenergic agonist and causes profound sedation. And so why is this like part of our drug overdose crisis? Like, why did this enter our illicit drug supply? So, if you actually look back into the peer-reviewed literature, you'll see that in the early 2000s, we began to see xylazine appearing in the overdose or in the illicit drug supply in Puerto Rico. And the prevalence of xylazine was about 30% across the whole island. But if you look specifically in certain areas like Arecibo, Waco, and Guanico, you'll see that the xylazine prevalence is about 98 to 100%. So, like, why is this so much higher in these three regions compared to the rest of the island? And if you actually look at the characteristics of these islands, these are predominantly cattle farming communities. So, we think that xylazine was being used as a veterinary sedative. It was primarily used as a horse and cattle sedative, and it was being diverted into the illicit drug supply to moderate the effects of fentanyl. So, for instance, illicit fentanyl has a very short half-life. So if you were to just use fentanyl by itself, you may need to inject maybe 4 or 5 times a day. But if you mix xylazine in with fentanyl, it causes profound sedation. So you may only need to like inject once a day. So a lot of drug manufacturers are sort of interested in experimenting with xylazine to moderate those effects of fentanyl. Um, So, as I mentioned, xylazine can sort of compensate for the shortcomings of other drugs. It can cause you sort of extend the effects of fentanyl, as I mentioned, and therefore, we began to see a lot of these polysubstance overdoses involving both fentanyl and xylazine. And secondly, xylazine allowed for market differentiation. So, drug manufacturers and dealers were always looking for ways to sort of stand out from their competition. And if you mix xylazine into your product, this often allowed you to distinguish your product from other competitors and sort of appeal to customers. And thirdly, xylazine involved overdoses were often unintentional. So a lot of people actually didn't know that they were being exposed to xylazine until later on when they may have experienced adverse effects. And then fourthly, there was really this very limited drug testing and public health surveillance, as well as compounded stigma from healthcare providers. So, what I mean by compounded stigma is patients with opioid use disorder or addiction in general face a lot of stigma from healthcare providers. A lot of healthcare providers feel like, it's the patient's fault for having an addiction, or they do not feel comfortable about treating patients with addiction. But xylazine really brought this to a whole new level because, as I mentioned before, xylazine can cause these pretty severe necrotic skin wounds. And so the like strong visual appearance and the strong smell of these wounds added to the stigma that was already there for patients with addiction. Um, um, so xylazine really spread around Puerto Rico pretty quickly after it was diverted from the veterinary supply. But how did xylazine get into Philadelphia, where we began to see, in those initial images I showed of patients who were profoundly sedated and in the streets? And so there's a few different reasons. The first is there was a need for specialized healthcare services to manage xylazine-related injuries. So a lot of patients. Who exposed to xylazine needed a higher level of care to treat their wounds or to treat, if they experienced like cardiovascular conditions or like respiratory conditions that needed a higher level of care. So a lot of these patients were actually moved to the continental US to receive the specialized care. And then secondly, there was already pre-existing demand for xylazine within these drug markets within Philadelphia. So a lot of drug manufacturers within these neighborhoods were within Puerto Rican segregated low income neighborhoods and sort of had ties with people in the island of Puerto Rico. So this may have also streamlined that connection. And then, so the purpose of this current study, so I sent a few papers along. One of them was a narrative review, and then the other one was a like a more data-driven project. So the goal of the data-driven project was to examine the rate of fatal overdoses involving fentanyl mixed with xylazine, also known as FMX, across different like U.S. demographic groups, geographical regions in years, using the most recent data available. So, what we did is we took a publicly available data source called CDC Wonder. CDC Wonder is a death certificate database. So, essentially, if you die in the US, you are given certain ICD-10 codes, which sort of specify the reason for death. And then those ICD-10 codes and those death certificates are recorded in a database like CDC Wonder. So we are able to sort of extract those ICD-10 codes and identify deaths involving fentanyl, which is the ICD-10 code of T40, as well as xylazine, which is indicated by T42 or T46. And we also broke it down by different demographic groups, including sex, race, ethnicity, U.S. Census Division, and state. Um, and the validity of this study was strengthened because these ICD-10 codes had a pretty strong correlation of 0.97 compared to other studies. We also use forensic data from this database called the National Forensic Laboratory Information System, or NIFLS, to look at drug reports across forensic laboratories in the US. So what we saw is within the past 5 years, so from 2018 to 2023, overdose deaths increased by 60-fold, from 99 deaths in 2018 to over 6,000 in 2023. And this is a massive, massive increase within a very short amount of time. Additionally, we looked at rates of death. So in 2018, 0.03 people out of 100,000 experienced xylazine fentanyl overdose death, compared to 2023 when we saw 1.8 per 100,000 experiencing this. So this is a very dramatic increase within a very short amount of time, and sort of goes to show how quickly the drug overdose crisis can evolve, and the impact that these novel adulterants can have on patients at risk for overdose. Um, Additionally, we saw higher rates among males, which is consistent with the broader literature. Interestingly, we also saw some racial disparities widening over time. So, in 2019, for instance, we saw equal rates among Black and white individuals. In 2019, about 0.2 per 100,000, but by 2023, the rate was higher for Black individuals than white individuals. So, Black individuals had a rate about 3.2 per 100,000 compared to white individuals who had a rate of about 1.9 per 100,000. So, if you have any thoughts on why this might be, we can definitely discuss after this presentation. But sort of also mirror some of the broader trends of the overdose crisis that Black individuals are increasingly being affected. And then thirdly, we began to see some regional trends as well. So what we saw is initially those black and green lines at the top, New England and Middle Atlantic had the same rates in 2018, both at 0.49 per 100,000. But by 2023, we began to see higher rates in the Middle Atlantic region, which is more in the middle of the U.S., and sort of supports our hypothesis that xylazine really spread across these like Rust Belt cities across the U.S. And gravitated away from epicenters in the New England region and sort of westward across the U.S. And then finally, we also saw some state-to-state variation. So this is called a dumbbell chart. Essentially, what it shows is the rate of xylazine fentanyl involved overdoses in each of the years listed below, 2018 to 2023. So we began to see states like Pennsylvania, Maryland, and Connecticut initially having some of the highest rates, but by the time we got to 2023, we began to see other places, including like Vermont, having even higher rates. So we really did see quite a bit of movement within the xylazine landscape. And then finally, these trends are also corroborated by NIFLS, which is using forensic reports. So essentially, a lot of the xylazine samples that are being like trafficked across the U.S. or transported across the U.S. are seized by agencies like the Drug Enforcement Agency, the DEA. And after they're seized, they're sort of tested at these forensic laboratories, and this uses different technologies like gas chromatography, GCMS, and we're able to actually use this database to sort of track trends in xylazine within these forensic reports. So in 1999 to 2015, we only saw like 1% of total xylazine reports. So it was not very prevalent early on, but in 2016, 2020, we began to see 9% of all xylazine reports, and 2021 to 2024, we began to see 90% of all xylazine reports, which really sort of supports our hypothesis that xylazine entered the U.S., in recent years, and once it hit like the streets of the U.S., it just spread so rapidly in infiltrating existing areas dominated by fentanyl. So, and again, we began to see sort of, if you look at 3A, we saw a lot of regional clustering around like the New England regions, such as Pennsylvania or like Connecticut. But then as you sort of look through 3A, 3B, 3C, and 3D, you began to see like this actual spread of xylazine from these New England regions across the Rust Belt and across the U.S. So our main takeaway is really that xylazine is one drug, but there are so many different novel adulterants, and it is really a symptom of a deeper pathology, which is the rise of that fourth wave crisis I mentioned with fentanyl, being mixed with a ton of different novel adulterants to create different psychoactive effects to increase profits for drug manufacturers and fueling this polysubstance drug crisis. We're no longer just dealing with opioids. We're dealing with a host of many different synthetic compounds. And in order to address this, we need partnerships and collaborations between health professionals, like physicians, researchers, public health surveillance, drug testing, and other stakeholders to address this crisis. So I think for you as aspiring physicians, as aspiring researchers, I think this is really sort of a microcosm of a lot of issues that we're seeing within the healthcare system. That we need people who are interested in medicine, interested in policy, interested in social sciences, and looking at disparities and looking at health policies and different interventions to not only be able to help patients within like a hospital or within a clinic, but also at a population-wide level. So, please let me know if you have any questions about the presentation, or what life is like as a medical student or as a PhD student. If you have any of your own interests that you want to talk about, I'm also happy to talk about that as well. And I believe we have some quick questions for you as well.
Yeah, so I guess before we segue into our Q&A session, we do have some kind of like snowball questions where we're gonna throw them at you. And it's just the goal is to kind of encourage you to digest the research articles in a bit of a more with a deeper understanding. I do see one question in the chat if you want to take that one.
Yeah, for sure. So the question is, why is fentanyl so much more powerful than morphine, and what makes it more dangerous? And is it obtained from the same plant or other? So that is a fantastic question. So when we are talking about how powerful a drug is, what we're essentially saying is how strongly does it activate the receptor? So fentanyl and morphine both target the same receptor called the mu opioid receptor. And this is an endogenous receptor. This is a receptor for endogenous compounds, which means that essentially our body naturally produces opioids. So, for instance, if we touch like a hot stove, or if we break our leg or something, our body will naturally release opioids, such as opioids and other sort of enkephalins, to bind to this mu opioid receptor, and this produces an analgesic effect, which is a pain relief effect. Morphine is a drug that mimics these endogenous opioids. So once you give someone morphine, it binds to that same mu opioid receptor and it activates it. And as a result of that activation, it causes pain relief. So fentanyl, what it does is it binds to the same receptor as well, but it activates it about 100 times stronger than morphine. So why is this dangerous, right? Like, why is stronger activation dangerous? Because not only does the mu opioid receptor cause pain relief, it also causes respiratory depression. So people who, are given morphine, they can overdose. It's possible, but it's kind of unlikely because the receptor does not is not activated that strongly. But if you activate that receptor 100 times stronger than what it's supposed to be activated as, this causes life-threatening respiratory depression. So a lot of patients die of hypoxia. So because their respiratory rate is so low because of fentanyl, they actually starve their brains of oxygen, and that causes they're dying of oxygen deprivation essentially. But great question. Thank you for that question. So the question is it a competitive enzyme action or different? That's a great question as well. So it's not an enzyme. So enzymes are sort of biologically active like proteins that can catalyze like reactions. So fentanyl is it's not necessarily a protein. It's sort of more of like a pharmacological compound. And I kind of equate it almost to like a parking space. Like if you um, sort of park where like endogenous opioids are normally acting, it will produce like the same effects as those opioids. So it's not like an enzyme in that it doesn't really catalyze reaction, but it sort of just parks where these endogenous opioids are normally parking, and it activates those receptors to a much higher degree than what is safe. But it's a great question when you ask about competitiveness because our main sort of strategy to combat fentanyl is something called naloxone. So naloxone is an antagonist. So it does produce competitive effects. Specifically, no, naloxone. Imagine like, you're trying to park somewhere and then some guy like swerves right in front of you and like steals your parking spot right in front of your eyes. Like you're not going to be able to park there anymore. So that's what naloxone does. It binds to these mu opioid receptors, but it does not activate the receptor, right? It just simply takes that spot, parking spot. So fentanyl cannot park there. And because fentanyl can't park there anymore, it can't induce life-threatening respiratory depression. So that's why naloxone is so helpful. I can literally take naloxone right now and be completely fine. Because what it will do is it will bind to my mu opioid receptors, but it won't activate it. So there's no harm to taking naloxone because it doesn't actually activate anything. But it just prevents fentanyl from binding and activating its effects.
That's a really great segue into like our first snowball question, which is what are the biggest challenges of responding to overdoses when naloxone is insufficient? So you kind of heard how naloxone is an antagonist. And so whenever someone, I guess I'm going to be a bit more specific in terms of like fentanyl mixed with xylazine, in those cases, what might be some big challenges that people face of responding to overdoses when naloxone is insufficient. So you can feel free to either unmute or type in the chat. We'd love to hear your answers. Hey, I see someone said in the chat, not knowing what exact substances are taken, I guess, because of the adulterants, if that makes sense. Yeah, I guess like not knowing what it may be mixed with together, or um, that might be something to consider. And also finding a cure that isn't an addictive drug.
These are both fantastic points and exactly what we're trying to do. So, as I mentioned before, a lot of people who are taking xylazine actually don't know that they're taking xylazine. So, one of the big points we're trying to do is increase knowledge and education of what xylazine is. So, for instance, if you are taking a drug and you are like asleep for the whole day and you are like really groggy when you get up, like that's maybe you're not just taking just an opioid. Maybe there's like some xylazine that's contaminating your opioid supply. So certainly that's a big consideration. Additionally, we're trying to expand access to xylazine test strips. So just like a COVID like rapid test, where you take the COVID rapid test, and then within like a few minutes, it'll tell you whether you have COVID or not. We're trying to do the same thing with xylazine. So essentially, if you swab your sample, it will tell you within a few minutes if xylazine is present or not. Um, and then with respect to finding a cure that isn't an addictive drug, that's also a great suggestion. Does anyone remember what kind of drug xylazine is? Pop quiz. Which adrenergic receptor does it activate? Yes, alpha 2. Great job. So, yes, it does activate alpha 2 receptors, which is sort of the brakes of the nervous system. And that's why it causes like these like sedation effects. But if you have an alpha 2 agonist like xylazine, what do you think is the best way to, prevent it from activating its effects? And the key word here is agonist. So how do you counter an agonist? Yes, exactly, an antagonist. So if you have an agonist which activates that receptor, the best way to fight it is by giving an antagonist. And that's exactly what we're seeing with drugs like naloxone, right? So if you have fentanyl, which is an opioid receptor agonist, you fight it with naloxone, which is an opioid receptor antagonist. So if you have something like xylazine, which is an alpha 2 receptor agonist, you can, in theory, use drugs. We have like a few different candidates, like atomeprazole, yohimbine, and a few other drugs that are alpha 2 receptor antagonists. And we're sort of trying to see if those can sort of reverse the effects of xylazine. So yeah. Thanks for your engagement on that. That was a great question. And then finally, someone said withdrawal symptoms. So that's actually pretty poorly understood for xylazine. We're not super sure what the withdrawal symptoms are, but this definitely leads to an atypical presentation of overdoses. So for those of you who are interested in addiction or like substance use disorders or mental health, just know that there are a lot of guidelines out there for how to treat these patients, but they're constantly evolving over time because risk profiles are changing over time. You know, things like xylazine or other novel adulterants are entering the scene and changing evidence-based practices for treating these patients. Which is why another reason I think medicine is like so rewarding because it's like there's literally an infinite number of things that you can continue learning about. Like there's just, you know, even if you're like the leading expert in treating patients with substance use disorders, once things like xylazine come into play, there's now a drug called metamidine, which is xylazine but 200 to 300 times stronger. There's sedatives like benzodiazepines, which are produce similar effects like xylazine. It causes sedation. There's also stimulants, including like cocaine, methamphetamine, and synthetic cathinones, which are these like bath salts that are synthetic versions of meth. Um, so there's like an endless supply of things that are constantly changing. So even if you're like the world leading expert in substance use disorders, there's still so much you can learn. And I think that's one of the most rewarding parts of medicine that it's just like a constantly evolving field. Very tangential to what you mentioned, but just my 2 cents on that.
Thank you so much. I guess just with respect to time, maybe we can do one more snowball question. So let's do, um, I think this one might be a good question. So, what ethical responsibilities do media outlets have while reporting on drug use? And I know we kind of mentioned like stigma before, but kind of going deeper into that, what do you think are like some ethical responsibilities? Someone said confidentiality, sharing information with the person's consent. I think that's definitely an important aspect to consider. Um, And then another person said, you mentioned stigma, so if the media could use non-judgmental language, definitely because of the times these people are considered to be failures. Safe practice, focusing more on suppliers rather than victims of the abuse. And I guess some other things to consider is like avoid using like labels like the zombie drug, and trying to like inform people without dehumanizing. So I
Mhm.
think these are all really great responses. I don't know, David, do you have anything else to add?
No, these are really great responses. And I definitely agree with all of them, confidentiality, stigma, and sort of focusing like moving the needle away from like sort of characterizing addiction as like a personal failure, like a moral failing, and more towards like addressing the structural drivers of the crisis, including like suppliers and other and marketing as well, as you mentioned. I think what this question makes me think of as well is the that words matter. Like if you are like a high school student or like a university student and you are interested in sort of raising um, awareness for a certain issue, or if there's like a novel adulterant or there's like a new policy, like people definitely read that and policymakers read that and it plays an important role. So there are ways that this could, make things worse. Like for instance, a lot of news outlets are trying like the reason I think they're using labels like zombie or like flesh eating or like flesh rotting or whatever, is because they just want to capture attention, right? Like we have an attention economy, and they want to, they want more clicks, and that's what gets more clicks. But that is very detrimental towards the drug overdose crisis because it moves, treatment resources away from those patients. People avoid patients who, are exposed to xylazine because, they don't want to be associated with like zombies or, it's very detrimental. So, but on the other side, there are a lot of people who are sort of promoting like what we call harm reduction. So essentially, that is a framework where we don't necessarily focus on abstinence, but more on, supporting patients who have addiction and trying to provide a more holistic support for them. So this may include things like providing them with employment services or like housing services or food, and like spaces where if they overdose, we can administer naloxone so they don't actually die from their overdose. So that's sort of a broader move towards like I guess humanizing the drug overdose crisis and like taking a more public health centered role. So if you're a high school student or like a university student who is interested in, speaking out about certain issues, it may be in neuroscience, it may be in substance use, it may be other topics entirely, but your words definitely have a lot of power towards advocating for, patients like, these patients, who would benefit from a lot of like positive, sort of framing. So, I would definitely, when I was starting out in research, before even approaching like a peer review paper, I just, worked a lot in trying to advocate for, people through just like news articles, and a lot of them didn't even land, and, I posted them on like LinkedIn or something. But, and, eventually, like the more experience I got and the more, I guess, I wrote, the more it sort of caught on. And I was able to get in like news outlets and in journals. So, if that is of interest to you, please do talk to me after this. I'm ha happy to help you sort of figure that out. But that was a very long answer, but I guess just my thoughts on the power that like news outlets and like research journals can have for good in healthcare.
Thank you so much. And also I'll put David's contact info in the chat if you guys would like that as well. And then I guess we do have a couple of minutes for like a mini Q&A session. So feel free to either unmute. It can be honestly anything that we talked about during today's session. So I think there's a question in the chat. Elizabeth said, for her first question, why do you think New England has a high prevalence of xylazine? And then her second question was, how did you discover your interest in pharmacological inhibitors and xylazine-related overdoses?
Yeah, thank you, Elizabeth, for those questions. I think they're really good questions. So, with respect to the first one, I think that New England had a high prevalence of xylazine because the Kensington market is an open air drug market in Philadelphia. And in the Kensington market, there were a lot of Puerto Rican drug manufacturers who maintain close ties with their, counterparts within the island of Puerto Rico. And we think that a lot of those drug manufacturers were able to sort of like traffic drugs between each other, and that caused the introduction of xylazine into the Philadelphia drug supply. So, and then from there, sort of, was increasingly mixed with fentanyl, and sort of just spread very quickly across the US. In addition, their patients sort of being treated for xylazine involved overdoses and exposure within places like New York. So that may have also, introduced xylazine into those areas. And then with respect to the second question, how did you discover your interest in farm inhibitors and xylazine? So that's a great question as well. I wouldn't say I was originally interested in xylazine. I was originally interested in the drug overdose crisis. I think it's such a fascinating, but also tragic story because it involves like every single component of our healthcare system and society as a whole. So, for instance, I took you guys through sort of medical and biomedical underpinning of this with how like different adrenergic receptors work and how like the nervous system and like its effects on the nervous system. So you have to have a strong understanding of that at a biomedical level, but then also at a population health level, at a public health level, you need to understand, the prevalence of xylazine across different states and across different cities. So you can allocate treatment resources and test strips and educational resources towards areas and communities that are hardest hit. And then also from like a social perspective, we began to see rising racial disparities over time. So, why are Black patients being disproportionately impacted, right? Maybe there are certain structural drivers that are causing, predominantly Black neighborhoods to have a higher prevalence of xylazine exposure. So, how can we also, from a social perspective, address that? And then finally, from like a legislative policy perspective, a lot of people are trying to move towards, and this is actually really interesting. Philadelphia, after xylazine sort of flooded their drug supply, they scheduled xylazine. So what that means is they moved it to basically xylazine is no longer legal. It's now an illegal drug. And like, what do you think that did? Well, that decreased the prevalence of xylazine, but that left sort of this vacuum where now there's like an empty space to be filled by another drug. So what ended up happening was medetomidine entered Philadelphia after they scheduled xylazine. And medetomidine is 200 to 300% more potent than xylazine. So really these like very like regressive like war on drug tactics of like scheduling a drug is very, very ineffective and something that I'm advocating heavily against. I think that instead of these like very criminalization heavy center strategies. We need more harm reduction and public health center strategies to actually expand access to treatment and education for people or like health education for people exposed to xylazine. So, that also involves like legal components and like policy components. So it's like such like a fascinating issue because it involves like biomedical and clinical knowledge. It involves policy and public health knowledge. It involves like legislative knowledge. And it's just so complex. So I think if you're interested in healthcare, definitely think about how these different things intersect because it's never just one thing. It's usually the intersection of all of these different fields. So hopefully that answered your question. So what's your future interest in research field? I am doing my dissertation on substance use disorders. So what I'm trying to do right now is I'm trying to develop an economic and use like economic techniques to develop a theory that economic decline led to the widespread proliferation of fentanyl. And the reason is in epi literature, we see that patients who are from racial and ethnic minority communities or who have lower socioeconomic status are predominantly impacted by by fentanyl. So, I'm trying to use different like health economic techniques to show that any economic decline led to the proliferation of fentanyl. Um, Next question is, how would we counter this very broad market of drug abuse? Like it's not a single category. Some are depressants, some are stimulants, and they're highly valuable drugs like snake bites. So yes, that's a great question as well. If I'm understanding correctly, the question is asking about, we have so many different types of novel adulterants that are sort of infiltrating the illicit drug supply. This is really complicating our ability to treat and monitor overdose trends. How do we sort of, how do we counter this if there's just so many things going on all at once? I think that's a great question. And I think primarily we need to get people to address the root causes of a lot of these issues. So I think there's a few root causes, as I mentioned before. Like when Philadelphia scheduled xylazine, medetomidine entered the scene and was a lot more potent and a lot more dangerous. So we need to move away from that, historical war on drug lens and more towards a harm reduction framework where, we're not, just scheduling, like playing whack-a-mole and trying to schedule these individual drugs and that causing the drug overdose crisis to be more dangerous and more unpredictable in future years. We need to move towards a more treatment-centered approach, and I think that will alleviate some of the evolution of the overdose crisis. And secondly, we need just more education. In medical school, we have a very, very biomedically centered curriculum. So, for instance, a lot of that like adrenergic receptor stuff, I just took off one of my like previous medical school like exams. Hopefully, that was of interest to you if you're interested in that pathway moving forwards. But we don't learn about like how, these different receptors or like these different biomedical concepts often intersect with these broader population health issues or like health disparities. So I think, if the medical curriculum was, I guess, I guess if there's more efforts to, incorporate this kind of training within medical curriculum or like residency programs, then I think it would be very helpful for people to help stay on top of these issues. All right. And then another question is how can we stop potent drugs like xylazine apart from making it illegal? And how did you get interested in medicine? So yeah, I think that like in terms of how can we stop these potent drugs like xylazine, um, as I mentioned, there's a lot of harm reduction tools that you can use. So, for instance, expanding access to like early detection. So, for instance, like test strips make it very easy for you to quickly see if it's in your supply. Sometimes, like it's a little bit harder to detect xylazine. So, you may want to also increase access to things like gas chromatography mass spectrometry, which is GCMS, which sort of like those like wavelength like monographs. Those are what GCMS outputs, and you're able to see like if xylazine is present or not using that. And additionally, just raising awareness because a lot of patients are not aware. And then I guess in terms of why was I initially interested in medicine, I think it's just incredibly rewarding to um, when patients are coming in with especially within addiction medicine, like I think it's very rewarding to be able to work with patients to develop treatment plans that are conducive to their own needs. And this may include the use of medication. So we have things like buprenorphine and methadone, which we call medications for opioid use disorder or MOUD. And that is very effective for treating opioid use disorder. And, it's very gratifying to work with patients to, be able to support their recovery from addiction. But then also, I see a lot of patients with broader social issues. And this is something we call social determinants of health. So, for instance, patients who like lost their job. And this is a patient I like recently saw like a few weeks ago. Like they like lost their job, and because a lot of at least here in the US, a lot of insurance is tied to your job. So it's called employer-sponsored insurance or ESI. So because they lost their job, they also lost their insurance. And because they lost their insurance, they were not able to afford buprenorphine anymore. And so this caused them to relapse. And so, you not only, should you prescribe drugs in that case, but you should also, refer them to social services where, they can support that patient in like getting a new job, or if a patient like lost their house and that caused a lot of stress, or patients who had like a recent death in the family and that caused a lot of stress and that led to substance use. There's a lot of like these broader social factors that need to be addressed along with the biomedical factors. So I think that like combination is super interesting to me. And this is a lot of the work we are doing in our new center, called the Center for Integrative Social Medicine and Population Health, and moving away from a purely biomedical conception of medicine and more towards these broader social factors and how it tangibly impacts patients' health outcomes and access to care.
I think that's going to conclude our Q&A session. I know we're kind of over 1 p.m., so if you have to leave, that's completely okay. So now these are just a kind of couple of final remarks. So the recording of this is going to be uploaded to Simply Neuroscience's YouTube channel. So I'm going to drop all of those links in the chat. And then also, if you're interested in attending future Synapse sessions, please subscribe to our newsletter for future announcements. You'll also get other research or kind of like award opportunities that they typically send out every month. And if you're interested in becoming a guest speaker at future Synapse sessions, please fill out the interest form. And then if you would like to have a certificate of participation, you'll need to attend at least 3 sessions, and then you can submit some brief reflections through that form. And so those are just some final remarks. And then we would also kindly ask if you could fill out a feedback form for us so we know how we can improve the Synapse session for future sessions. But we truly thank you so much for coming. And then I'll pass it off to David for some final remarks.
All right, thank you so much, Danielle. So, in terms of final remarks, I would just say that if you are interested in healthcare, um, there are so many different opportunities for getting involved in research, from both like a clinical perspective, from like a wet lab perspective, and from like a social population health perspective. Um, if you think of something like xylazine, you can tackle that at the biomedical level. So, for instance, if you wanted to work on like working with rats and injecting them with like an alpha 2 adrenergic receptor antagonist and seeing if that reduces, overdoses or exposure to xylazine, that could be an interesting direction. Or, you can sort of work in my field, which is like population health, and see, are there disparities in xylazine involved overdoses? What are the sort of the population level trends in xylazine? Or you can work on sort of the legal level, like, are there ways that states can sort of allocate like funding or like legislative support for programs that, expand access to xylazine treatment? So, where you are right now, there's so many different opportunities to get involved in research at many, many different levels. So I would definitely encourage you to, start reading on about things early, like find topics that, if this is something that's of interest to you, like find topics that are interesting to you, like get in touch with people, even if it's like a 30-minute call and it doesn't pan out into a research opportunity, like, that it would help you better understand the issue. And maybe like the next time someone would be like, oh yeah, like I think you have a great background or interest in my lab. I would love to have you come along. So if you sort of there's so many opportunities out there. And if you have any questions for how to get involved, I would be happy to help give some pointers and help give some guidance. So feel free to reach out to me anytime. And yeah, those are my final remarks.
Thank you so much. So I guess that's the conclusion of our December Synapse session. So I'll stop recording right now. But thank you so much for coming.